Hello, and a warm welcome, or good morning, or good evening, wherever you are in this world, on behalf of BioHorizons ChemLog to this webinar on CONELOG progressive line implants in edentulous patients featuring the COMFOUR concept in immediate loading. I'm Michael Neckmus. I'm a senior instructor international education, and I'm your moderator tonight. But before we start, I would like to point out that after the 1 hour presentation of Dr. Damien Carotte, we will have a 30-minute Q&A session. And in order to ask your questions, in the lower part of the screen, in the Zoom screen, you have an icon which is F and A. So please, for your questions, use this feature. Do not use the chat, because then this will be confusing if you use both ways. So please make sure that you use the icon F and A. That's where we can see your questions, and of course then we will, after the presentation, answer the questions. But now it's time to introduce our speaker, Dr. Damien Carotte. Damien, good to have you with
Yes.
us. How are you doing?
Yes. Hello, Michael. I'm very fine and great, and happy to be with you tonight.
Hey, same here from Basel, from the webinar studio where I'm currently sitting. And Dr. Damien Carotte, he has his private office in Villeurbanne, a city very close to Lyon in France. So it's more or less the center of France. He works there with 5 other clinicians and a big staff team. And what is very interesting, already at the age of 7, he started to dream to become a dentist, or even better, a dental surgeon. And he never gave up his dream and changed his mind. Isn't that amazing? And then in the year 2000, he really became a dental surgeon. And he started to work already on the all-on-4, or with the all-on-4 concept, starting in the year 2005. And then following this time, actually, he went 3 times to Lisbon, to the Paulo Malo clinic, to actually attend different courses on the concept. And half of his activity today is really doing all-on-4 cases. And he has a master degree in implantology as well as in prosthodontics and a lot of other diploma, but I don't have time actually, otherwise we will not have enough time for his presentation. But I would like to point out one point. He is as well, together with Dr. Jacques Vermeulen, the scientific president of next year's French Oral Reconstruction Symposium. So from the Oral Reconstruction Foundation, we have national symposiums, and Dr. Damien Carotte is the president. And then, well, I said enough. So Damien, the stage is yours. I invite you to present your really interesting topic now.
Thanks a lot. Thank you, Michael, for this kind introduction. And now I will say hello to everybody from all of the corner of the world. And now I'm happy and I'm very proud to talk about the all-on-4 techniques with you and to share my my way of working. So I can start it if you want to launch my presentation. So, you know, I'm very happy to share my my experience on the all-on-4. Just before to start, I want to acknowledge the team of ChemLog and BioHorizons, and Andrea and Michael, who helped me a lot a few days ago, and the French staff in France. So you can see in the first slide, we talk about the all-on-4 technique, but we can talk today with the all-on-4 or all-on-6 technique, because this is a good question. This is one of the aim of the discussion, to say if we need 4, 5, or 6 implants to make immediate loading in a full arch rehabilitation. And you can see different type of implants, because as Michael said just a few minutes ago, I started 15 years ago, and I have a lot of brands of implants, and you can know that everything is working when you have the good technique. Of course, a good implant, but when you obtain the good insertion of your implant, you can realize All-on-4 easy.
Damien, could you
Yeah.
just do me a favor? In order to really appreciate your images more, could you go into the presentation mode? Because then we would see your image larger from your presentation, please. Huh?
Okay, sorry.
Yeah,
Of
no
course.
worries. So,
Yes,
much
I
better.
forgot.
Thank you, Damien. No worries. Very good.
Thank you. Thank you, Miguel. So no, I think you have seen this first slide. This is the aim of my presentation, to see the full arch immediate loading on one jaw or both jaws. Okay, so this is the jaw of COMFOUR. It's interesting because you see we have 4 implants in the mandible, but we have 6 implants in the maxilla. And this is the huge discussion everything is having during 20 years now, because Paulo Malo said that it's the All-on-4, and I think it's not All-on-4 each time, because it depending on the quality of bone, and we will see that it's depending on the overarch. If it's natural teeth, it is completely reconstruct by ceramic or resin components. So it's depending on the other arch. So we'll see all the materials provided by CONELOG. You can see this is a draft of the screw line implants. You can see the abutment, the index position. This is the cap. How they said the cap for bridge bar abutment in CONELOG company. It's a big term. And you see the straight abutment. And just, sorry, because I have my face. And here you can see the tilted abutment. The notion of the height is very important, because you will see on the other side that this height is depending each time of one parameter. And when you are doing an immediate loading surgery, you just need one height of transgengival height. This is the 4 millimeters of height. So I just talked to you about this height. Okay, so I'm sorry, I have a problem. To follow, it's not following. Okay, so I have okay, thank you. It's working, sorry. So this is in the real life. The case of a man is emblematic of the surgery of the All-on-4. You can see on the lower jaw, the screw line implants by CONELOG, by COMFOUR in France, when using COMFOUR. And on the upper jaw, you see the progressive line, and you can see the area of bone is concerned by the surgery. You need to clean up all the mouth, because this is one of the factors of success in the All-on-4. And you can see the connection, and this is my French touch, because we have to make a reinforced bridge. I think it's very important. So you have the principal aims of the All-on-4 on this slide, and in first this real case, you know, it's important to, and perhaps it's the first of all, first principle, you have to check the lip, the quality of the lip, and the smile line. When you're starting a surgery with the All-on-4, you have each time to check this support, this lip support, and this smile line, and you have to appreciate the the rapport. You have to see what is the position of the lip before the surgery to know how many bone you have to remove. So what few words about the history of the Holland-4. You can see that it's a technique described by Paulo Malo in 1993. And he think about this technique with the aim and with the demand of the patient. And he said that it was an approach for using reconstruction with a fixed bridge or reduced number of implants. And the success of the technique is very, the success rate is of entirety of surgical procedures. Using the whole implantology, you know, where we have the best rates of success. And Paulo Malo observing on the literature what you can conserve for only obtain the best long-term results, and excluding everything was increasing the failure risk, like a sinus floor elevation, unlaid graft of two surgical stages. It's very important because this is, I think, my opinion, the first way of a failure of implants with a bad stay of the prosthodontic and the gingiva, the low quality of bone areas. You know, like Carl Misch said that you have 4 degrees of level of bone, and you have to focus your surgery on the best quality of bones. So it's on the premaxillary and the upper jaw, and it's between the two foramina in the mandible. And you have to avoid to make your surgery in the bad outcomes bone zones. It's just above the sinus in the upper jaw, and the lower jaw, you know, it's with a poor vascular vessel bloods in the posterior zone area of bone in the lower jaw. And one of the failure level is the repeated handling of prosthetic components. You know that each time you are screwing and unscrewing your abutments, your hailing abutments, you are breaking all of the periodontics area, and you have to avoid to unscrew each time the components. And of course, it's an occlusal and biting concept. So we will talk about prosthodontics and the mechanics approach. You have to check the unfavorable periodontal environment, because if you are placing implants between tooths who are very in the bad situation, each time you can have a contamination by these tooth to your implant. So it's better to choose to extract the teeth, even if the teeth is is safe. And this is a strategic extraction definition of safe tooth versus the maintain of this tooth in the arch. The full arch bridge immediate loading on 4 implants must work as a similar function as other techniques, with the same outcomes and predictability supported by an uncompromising protocol. If you decide to place only 4 implants, you have to make a good job. You have to be sure that each implant is in the best position, is correctly placed with a good torque of insertion. So you can count about this implant. So you just have 4 implants, so it's very important to trust in alls. And now we are 1 hour for understanding the Holland-4 therapy and the key steps of an amazing long-term survival rate, because you'll see my statistics in the end of this presentation. And we talk about the favorable cases detection the couple between the surgeon and post-orthodontist management, because it's very, this is one of the key of a success. And we talk about outcomes and failures management. So what is the guideline? You need only 4 implants for full arch bridges, rehabilitations, whether on the upper or the lower jaw. It's depending, I said a few minutes ago, of the other jaw, of the opposite jaw. But 4 implants, if you have a big distance between the two foramens, it's easier to place 4 implants and to place immediate loading bridge with 10 of 12 teeth. No implant on posterior area. This is the explain of my introduction, because you have a low bone quality on the lower or the upper jaw, and you have to tilt implants up to 45 degrees in the back of the arch. Up to, because sometimes you can start to tilt it, your implants between 15 and 55. But it's important to have a guide, a surgical guide to show and to check your tilting of your implants during the surgery. And the fourth point is to deliver a reinforced acrylic bridge at the end of the day, because this is the demand of your patient each time. Since the born of the implantology, the patient wants to wait for 3-6 months or to wait with the removable prosthodontics. So it's important to propose to a patient to deliver the full bridge at the end of the day. What are the goals of the immediate loading with a full arch bridge? The first is to provide a high survival rate, of course, because you can't propose to your patient a technique is not working. You have to get the best for your patient. So you can't providing not a high survival rate procedure. So this is mandatory to get the same statistics with your techniques on the All-on-4 as the reference techniques of surgery. You need to obtain a perfect function and aesthetic aim at the end of the surgery, at the end of the day, because this is what your patient is waiting for. You need to provide a high level of hygiene for your patient, because if you remember, the level of the hygiene control of your patient is not the best of the world, because if there was with a good hygiene and a good knowledge of the hygiene, they can't pass through your door, your cabinet, and to ask for this technique. So you need to provide prosthetics with simplifical level of hygiene. Enable the patient to get fixed tooth the same day. This is the condition. And you know that when you are providing a bridge on only 4 implants with your prosthodontic colleague, it's easier to provide a fixed bridge the same day. If you are 6, 8, it's difficult. And if you are 10 implants, it's impossible to provide a bridge at the end of the day. The prosthodontics needs to have 10, 12 hours if you make a big full arch bridge. So with only 4 connections, it's easier for your colleague prosthodontic to provide you the bridge for the night. And the cumulative points of the 4 first points are meaning us to the 5 points. The 5th point is to cut costs, because if you want to provide surgery with a lot of patients, if you want to provide this type of surgery for the most number of the humankind, you need to cut the cost, because there's only 1% who can pay for the classic bridge. So if you cut the cost, you can open the panel of your patient, and you can provide some surgery for a lot of patients. And the last point is to make the technique accessible to as many people as possible, because this surgery is a universal protocol and a repetitive protocol. So when you make this technique, each case of surgery, you are growing, you get the progress. So this technique, in the long of your career, make this accessible to a lot of person, a lot of colleague surgeons. Definitely. Sorry. What is the principal level of attention you have to see when you're starting and detection for your cases, your patient? It's to check the large and the height of the bone and the residual bone. You can see on this slide on the upper and lower jaw what we need for the width of the bone. And on the upper jaw, it's 10 millimeters of height and 5 of large. And in the lower jaw, it's 8 millimeter high and 5 of large bone area. So you can see these patients are very usual patient. You can meet on your office, your private office, because each time this patient don't spend a lot of money for the take care of their mouth. And when you're talking to us about your technique, when the technique is very expensive, all your patients are not ready to hear it and to do and to realize the technique. So it's important to provide a low cost technique for this sort of patient. On the upper jaw, you see this is a premaxilla, and you see this is a triangle, and you have you have available 15 millimeters of bone in a tilted position on the posterior area of this bone. You have to check the front of the wall of the sinus. You have to check where is the level of your osteotomy, because this is the level of the bone with the periodontal disease. And you know that this bone is not good quality. So you know that you can use this bone to place your implant with safety position. This is the same on the lower jaw. So you have to be careful with the nerve, the inferior nerve, and to check the foramen. When you make your osteotomy, because you are cleaning the bone and you decide to place an horizontal line of safe bone, you have to take all of the area of the bone, because if you can get very close to the wall of the sinus, you can put the posterior implant the more posterior as possible. So you're opening the surface of the powerful of the bridge. So it's very important to put very posterior as possible, and you have to make a little opening on the sinus to check the entire wall of the sinus, and you check with a periodontal probe, and you see what is the width of the residual bone between the the implants where you choose to place and the end of the bone close to the sinus. You put 2 implants tilted in the back and in front, in position of lateral incisor, you place 2 straight implants. And in the lower jaw, this is similar. You place very close to the nerve your tilted implant. So with your periodontal probe, you have to check where is currently accurate, with very accurately, this area of emergence of your nerve. And this is the jaw of CONELOG, where you can see we try each time to be very close to the nerve and to tilt the implant at 45 degrees and to place the abutment. The abutment is correcting the axis of 30 degrees. And after you have a conical connection, completed the correction of the tilted implant to up to 45 degrees. You place your abutments, so straight abutments in front and the back, angulated abutment. In the back is the same thing. And at the end of the day, you can deliver your prosthesis, and your prosthodontic is up to 12 teeth, but sometimes you can't provide this number of teeth, so you have to speak to your patient and to ask to tell her before that perhaps 10 teeth is sufficient. You know, to choose the size of the implants, when you are accounting the surface of the implants, the bone to implant contact, the beak, for 2 implants of 4 millimeters of diameter and 10 millimeters of length in the front, and the same but 15 millimeters of length in the back, send you 6.28 centimeters squared. You know, this is the surface ideal. This is the best surface to provide a good bridge at the end of the day for an immediate loading for 10 teeth. And you see on this slide, this is 3 months after, when you validated the osseointegration, you can add the first molar. When you place 4 implants, you see this sentence of Paulo Malo that the more titanium you put, the less bone you have. This is a good appreciation of the volume of the bone and the volume of your implants. So sometimes if you place 4 implants, you can see on this slide, if you want to place 3 implants of more, it's possible, but you're just making out your bone, but you can get nothing of good stability of more. And in the end of the 20th century, you have currently this sort of slide, this sort of X-rays for the patient with a lot of implants. It was the knowledge of this time. And today, I think it's very not indicated to place so closed implants as here. You don't need to place 8 or 10 implants in the lower jaw, because there are 2 levels of comprehension. First, the surface, the raw surface of the implants is increasing the stability of implants. And now we know we have a better knowledge of the osseointegration, and we don't need to place a lot of implants as these pictures. And to provide and to place 10 or 20 or 12 implants, you need to make some sinus floor elevation. You need to make some graft, vertical grafts, only grafts, and this is very difficult to realize. It's very high cost. and is not predictable on the long term for every patient. So when you're providing this sort of surgery to your patient, it's very difficult to realize. You have a very, very low rate of satisfaction, of acceptation of your patient treatment. So when you are placing implants only on the bone you have on the jaw, it's a better choice. It's very cost, and you can provide a full arch bridge only with 4 implants, as you can see on this X-rays radios of patients. You can recognize the screw line implants on the lower jaw. This is my technique. Sometimes we have a lot of bone and we don't need to tilt the implants in the back area. And you see, I was very happy to know that CONELOG provide a progressive line implant, because it's better choice for the upper jaw, because in the maxilla, the quality of the bone is very low rather than the mandible. So to read the good torque insertion of the implant is very important. To get an implant with this design, this shape, it's better and easier to obtain the good torque insertion of the implant, approximately about 40 or 50 Newton per centimeter. This is immediate loading bridge, and this is the final reconstruction with this sort of reinforced procedure inside the bridge. This is where I learned the technique. Somebody can know the Malo Clinic is a big building, and this is why I trust in Paulo Malo, because I think that you can't make a mistake for 50,000 cases of patients during 10 years, make a big building and be the most bad man of the world. So I think that when I start to learn this technique in the Malo Clinic in the 2005, I decide to follow this man and his conception of the surgery. This is one of my first cases, and you can recognize the disease of the periodontal level. And we had a lot of mobilities of tooth. So you need to make this surgery with only one stage. You extract your teeth, you make your osteotomy, horizontal osteotomy, you clean the bone, and after you can realize the placement of the implants. This is the type of the most we can see of our patients. And this is a result 1 year after the surgery, the first surgery of the upper jaw, and the year after it was the second surgery with the lower jaw. And this is the result of the healing of the gingiva. Just 10 days after the surgery, you can see a little blood because the stitch has removed. And the design of the entrados of the prosthesis, you can see here, it's important to ask to your prosthodontic to make this shape of the entrados of the implant, of the bridge, because it's guiding the healing like a mirror on your gingiva. So you place the bridge at the end of the day after the surgery, and when you're screwing the bridge, your patient can have a little pain, but he knows because you explain to him before the surgery that at the end of the day you need to place the bridge with a leisure compressive force to get the healing like a mirror, of the gingiva, and it's very comfortable and very easier to clean during the life of this bridge. And here we can see the healing 3 or 4 months after the surgery. And you see this is this circular form of the gingiva who received the bridge, and this is the shape, the design of the bridge of the Edentulous. It's very important to be convex, never concave, never, because it retains some food, and it's not easy to clean up. And I just told to my patient they have to use a hydroxy jet. You know, it's like the Karcher to provide a high level of hygiene, just under the prosthodontics. Each night they need to pass this oxyjet. And this is a situation in front of you. And this is 7 years after the first day that does the surgery, with the same bridge, with the only immediate loading bridge, the first. This patient is again wearing this type of bridge today. It's incredible, 10 years after, and is functioning. And this is the healing 7 years after. And you have the X-ray observation. We have a follow-up of the X-ray of the patient. So 3 months after the surgery, we can see the quality of the bone. Just it was a whole design of implants with a micro fillet. And you see, we have to check the level of the bone on the straight implants and what is the evolution of the level of the bone in the tilted implants. And you can see 7 years later, we have a densification of the bone on the posterior implants. So it's incredible, but if you think about it, it's normal because the implant is working on the right axis when it's tilted in the back of the mouth. When your patient is biting, he's biting along the right axis of the implant when it's tilted. So you have a good ossification, a good bone density around the neck of the implant. And this is this case after 11 years, sorry. You see, sometimes we need to make a little clean to help the patient to provide the good hygiene, but it's a little problem. Sorry, and you can see here, this is the adjunction of the first molar. So we take the prosthodontic for 1 day, 5 months after the surgery, 2 months after the osseointegration control, and we give the bridge to the prosthodontic colleague, and he made the adjunction of the first molar because it's very important to obtain a good concept of occlusion for this patient to avoid to have some temporomandibular dysfunctions. So this is a timeline to remind us of the all-on-4. On the first day, you got the initial consultation. You talk about the code, you take the CT scan and you give the explains of the surgery. It's very important to explain all of about the life of this type of surgery, of treatment for your patient, because we know during the 20 years after how is evolving this treatment. So you have to explain to a patient what are the days after the first surgery, what are the different stages for the follow-up, and what he can waiting for. 2 weeks after, we have a second date, a second rendezvous. We take the impressions, we take photos. We receive the agreement of the patient, of course, for the surgery. And we talk about payment facilities, because all of the patients are not, of course, so rich persons. So sometimes you have to manage the facilities of payment. And 2 weeks again after this date, you have the third date. This is the day of the surgery. So the patient pass all the day with you, the morning with the surgery and the impression, and after at the end of the day, is waiting on a room with a nurse. And at 6 p.m. we deliver the prosthodontic. 10 years after, we remove the stitches, because it's a good time to see again your patient, and to speak again about the importance of the diet. It's very important to bite only smooth foods, no bread, no meat, only fishes, only eggs for the proteins, and they are eating all of the smooth foods. And 2 or 3 months after, depending on the jaw, you have the fifth date with control of osseointegration. So you're validating the torque of the implant. You remove the prosthodontic, you unscrew, and you give a force of screwing the abutment on the implant, and you check if the implant is correct inserted and if the healing is good of the implant. And you can explain to your patient that he can get a normal diet return. Let's talk about the biomechanical principles. You know, sometimes the mechanic is very strange, but the Mother Nature is a good constitution. So if you realize, if you try to understand the forces in the evidence of this treatment, you can see the difference between 5 or 4 implants, because these 5 implants was the treatment as modern brandmark technique, like brandmark says in the 70s, and with 4 implants with the Paulo Malo design. And you can see the force and the division of the distribution of the forces along of the bar. And you can see that when you put a little force on the distal arch, you have opposite force on the 2 front implants. So it's very important to know that each implant is very important for this technique. You see as a 2D modelization, this is the same thing. And you can see what is the increasing force of the bottom of the implant in front. So it's very important to place all of your implants with a good torque and in the good quality of bone. And you know, you see that there's a rise of the strong forces on the front implant when you're placing only 4 implants. Why sometimes we have 5 implants? Sometimes we don't meet the expected quality of bone, and sometimes we have mandatory to place small implants. So to have a balance between the 2 sides of the arch, if you have 1 implant with a low rate of insertion, approximately about 10 newtons, you need to place another implant because you need to realize your immediate loading, and you have seen just before on the jaw of the biomechanical principle that this implant is very important when the patient is biting, because your patient will bite even if you forbidden to it to bite. Sometimes it's biting, so and you can have a control each time of him. So you need to have a good placement of all of your implants. So if you are a lower level of insertion of one implant, you need to place another one. So this is the reason of 5 implants in this case. Sometimes it's arrives. And this is the case 5 years ago, after with the final prosthetic. And this is the dealing during the impression of the second prosthesis. So you can see and appreciate the color and the quality of the gum. The gingiva is very stable. The level of the gingiva is correct. And this is a good satisfaction for us when we are unscrewing the bridge and we are checking this quality of the gingiva. This is the second, the final. I don't like to talk about final prosthesis because the final, for me, the life is very long, and the lifetime of this type of full arch bridge is around 10 or 15 years, not so much. So the final reconstruction, I don't like to use this term, and I prefer to say the first and the usual bridge. And this is the smile of the patient. And when you have with 6 implants, I told you in the first time of my communication that it's important to place for 6 implants, depending on the quality of the bone and the quality of the antagonist jaw. So when you have small bone, small area bone, available disponible bone, it's better to place small implants in diameter, about 3.4. And in this case, you have to augment the number of the implants. So you place 6 implants is better because you need to have the same bone to implant contact cumulative around 6 or 7 centimeters squared. And you have every time to get this proportion in your head to obtain a good bone to implant contact cumulative between your implants. Sorry. So what about the literature? Just we don't read about all of these lines, but it's just to tell you that it's an old technique with a lot of publication in 7, in 5 of this century, in 3. So there's a lot of literature about the CONFOUR technique, and some literature are very important, like this publication with, of course, Paulo Malo of immediate rehabilitation of Edentulous jaws. It's a big publication with 173 patients, and CONFOUR techniques with this lot of implants. And the conclusion is very important because everything is working. You see the cumulative rate of success, but it's important to write that there's 15%, 14% of broken of the acrylic bridge at 12 months. So you have to talk to that to your patient. It's very important to tell us that it's usual to have a broken of the acrylic bridge during the first year or the 18 months after the surgery. And this publication of Duick, full arch implant restoration implants, is supporting the forces of mastication at the 2 posterior and the 2 anterior implants, no matter the number of implants used in the reconstruction. So it's very important to get on your mind this publication, because only 4 implants is enough to realize a good planification of your treatment. And this is a publication of me during my master class of my law agreement. And this publication too, because it's a publication on 1995 from Brandmark and Svensson and Van Steenberg. And the conclusion of this 3 months, they place 156 implants with 4 or 6 full arch bridge, not in immediate loading, but it was a technique 10 years before in 85. And their conclusion after the good success of this technique, approximately 85% of success rate. This is this conclusion, and they said that the present tendency in 1995, the present tendency of some clinicians to install as many implants as possible is in full edentalism should be seriously questioned. So since 25 years, we don't talk about this publication. Instead of knowing this importance of this publication. So my outcomes during my first stage of work during 6 years, and you can see the number of treatment patients, and you see my rate of success. It's close to 98% of success of implants. But you know, with 4 implants for your patient, when you have a failure, it's 100% of failure for your patient. It's not a little number of a statistic. For your patient, it's a big failure. So you have to talk about the failure of your patient and not of your implants. So when I get this rate of success in my first stage of my activity in the All-on-4 technique, I said that it was not the good rate of success because 8% of my patients were very unsatisfied, and I have to progress because it was not easy to manage this volume of lack of osseointegration of implants in my activity in my private office. So I have to grow up and to progress in my technique to provide better outcomes to my patient. And on the second time of my career of this technique of the All-on-4 techniques, you can see the result of my statistics, and I obtain the good level of my objective, of my aim of this technique, of this procedure, because this is the similar result as Paulo Malo says in the last literature I show you. And this is the good rate of success is compatible to your work in your private office, and your patients are very recognizant of that. So, and when I start to work with a CONELOG COMFOUR technique, you can see that this is a similar success rate, perhaps a little bit better, but because I make a lot of attention of my surgery, so perhaps this is while I increase my rate of success. But you can see this is very good success rate, and this is my best rate of success in all of my whole activity in implantology. So I like to work with the All-on-4 technique. I have 7 patients that require a new surgical treatment, and 3 of them with a new implant placement and a prosthetic modification, but not to return to a removal prosthetic. On each time it's a fixed bridge, but you have to cut and to modify the bridge if you have to replace a new implant. And I think you met a lot of patients like my patients in your cities. This is the first consultation of my patient, and you can see that everybody is different, but each time it's a good défi. And this is the treatment we'll provide for them. And this is the result of a lot of cases. You see each time is the same thing. You clean up the mouth, you extract the tooth, and you place your implants in each time one or both jaws to clean the mouth. Each time it's the same procedure. So it's reproductive, it's predictable, and it's universal. So you have got a beautiful line of progression, a beautiful curve of increasing your capacity. So this technique allow for you good predictable results. Sorry. And this is so all of the cases you can see with different type of implants and different type of reinforced bridges. All cases with the healing situation, when sometimes we have to unscrew the brace for doing some repairs of the acrylic resin. And this is the result of the smile of the patient. I'll show you one case of a failure. It was a patient with a little pulse on the apex of the teeth. So we decide to extract this tooth and to place our implant in the same day. It was difficult. We make a big bone graft. This is the X-ray at the end of the surgery. And what we said 3 months later, we see that this implant had a lack of osseointegration, stability, and you can see the infection of the bone. So we decide to cut the prosthesis, and we place a new implant, and we let it healing alone for 3 months. And after, we connected this implant to the older bridge, like this. And we give the bridge with the analogs on the prosthodontic. And at the end of the day, we provide the modification of the prosthesis, and we check the occlusion function. And the patient is comfortable with the new bridge and the reparation. So what is the timeline of the long life of the All-on-4 technique? This is after 3 months, you will see the first molar adduction of replacement of the teeth, because there are no occlusion contact on the posterior area of the bridge, only between the canines and the central and lateral incisor during the 3 months of osseointegration. Until the first year, you can check the control and do your repairing of the prosthesis. 12 months, you take a X-ray control to check the level of the bone. And during this time, you are working about the opposite arch rehabilitation. And after the 1.5 year, this is the long period of risk of broken of the acrylic bridge. And all you say, to your patient is before the surgery is an advice, and when you say after the surgery, it's to apologize. So you have to think about the advice before the surgery for your patient. During 5 years, you can stay with the first prosthesis, usual prosthesis, and you decide to do the final prosthesis with a cast bar, machine bar. You choose the materials, acrylic or ceramic, and you check the vertical dimension if you need some modification, because this is the principal origin of the broken prosthesis. This is a dimensional, vertical dimension. And after 15 or 20 years, renewing the second prosthesis with a replacement of the teeth. This is how we replace, and we do for a second prosthesis. After 10 years of surgery, you repair the prosthesis, and after you decide to take a new impression with cast, with a plaster. If this is the best of impression, you can use at this level, at this time, you can use a digital workflow if you want, because the blood is not a problem for this stage of impression. And you can see with the plaster how we do a beautiful prosthesis. This is another case, only for showing you the type of the new bar in the acrylic bridge. So this is a plaster impression. You can check after 6 or 7 years the quality of the gingiva. And this is the type of machine bar and the prosthesis, usual prosthesis. This is a case with a CONELOG. We talk about the level of the bone we have to remove, and to provide the adjunction of the resin acrylic, because it will be very, very bad aesthetic if you make a long teeth to connect the implant with this huge osteotomy. So you have to report it on your previously program of the surgery. When your planification is correct, you can decide the type of your implants. Be careful of the level of the sinus in the bottom of the mouth, and you place your implants and your prosthesis at the end of the day. And this is the healing of the patient 3 months after the surgery. So I'm sorry because I'm a little bit late, and this is a movie, but perhaps we can follow this presentation with this video, Michael, because it's perhaps around 1 hour of speaking, and you can tell me if I show this video.
Maybe you can, yeah, I think you can still show the video, because of course this is quite interesting, but maybe just move forward a little bit
yes, okay.
in the procedure, because we have at the moment, we have 2 questions
okay.
coming in from our participants. So we still have some time for the movie.
Okay, so I make a little bit quickly with this video. Okay, so I comment you this surgery. We take the vertical dimension, of course, anesthesia, and we have just checked before, when Michael was talking, we checked the light line and the smile line to see if we have to remove a lot or a light quantity of bone. This is a particular incision I do during this surgery, because we don't need to stitch all the papillas between them. we need to cut and to conserve a quantity of keratinized tissue, but we cut it horizontally because we make a good periodontal cleanup, because it's not a good quality of gingiva here. And it's easier to stitch after the end of the surgery. So we have to place all of the gingiva. We stitch the gingiva side to side, easier when we cut like this. So we proceed to the extraction of the teeth. This is the periodontal extraction with the desmodontium and the gingiva around the teeth and the socket. You make the full flap. And there's 3 times we said to the patient. That's the time of the cleanup, the time of the implants, and the time of the prosthodontics. And there are equal times, 20 minutes, around 20 minutes each. So it's very long to clean all of the mouth. You have to make the cleaning of the gingiva, the cleaning of the bone. And after the cleaning of the bone, you need to check the level of the bone, because you have to hide the connection between the acrylic resin and the gingiva of the patient, just on the ridge of the gingiva. And when the patient is smiling, you have to hide behind the lip this connection between the prosthodontic and the natural gingiva of the patient. And you make the shape of the bone, because at this moment you decide the design of the prosthesis. So if you make a flat bone, you can provide after an introduce of the prosthesis with a convex design. This is the placement of the axis to be parallel and to provide to the patient exactly the, yes, we check the symmetric side. If it's on the middle of the jaw, we can replace it by the surgical guide. This surgical is easier to give the ideal form of your need. And this guide after sterilization is going to his initial form. And you have some lines with the angulated index. We make an opening on the sinus to check where is the front wall of the sinus, because it's difficult to check now where is accurately place the wall of the sinus. And with the probe, we are reporting with a pencil, carbon pencil, on the bone, with a carbon pencil with wood. So it supports the sterilization. You see it's broken, the wood is broken, but after it's going to the bin. And we place the posterior implants, tilted implants. with the beautiful drills like bone traps. You get a lot of pristine bone with this drill. And after we place the implant, we'll talk approximately about 40 newtons by centimeter. Wash with the physiological serum. Place the abutment. Screw with a ratchet for good control on the couple of screwing with 20. Okay. Make the same. Sorry, it's quick. We make the same on the opposite side. Place the abutment. And after we can realize, you see it's on the palatal position of the ridge, of the bone ridge, we start to drill because we want to place a straight abutment. With straight abutment, it's easier to manage the aesthetic outcome in the front area. And we place the implant. Finally, with the good torque of insertion, and we finish with that ratchet, and we place the abutment with the driver of abutment. And when you finish to place your abutment, you choose to manage the keratinized tissue to finish to clean a little bit. You see, it was like a half papilla. I make it to place good quality of gingiva just around the neck of the implants. This is a autolog bone. We kept during the drilling and the stitch. After stitch, we place the cap for bridge for bar abutment, and we place this. This is a copy of the aesthetic project, like a removal complete prosthesis, and we make a copy with transparency resin, and we connect the caps to this template. This is for bite registration, sorry. We unscrew the system and we screw the analogs of the abutments. And this is the X-ray at the end of the surgery, and the night at 6 p.m. This is a prosthesis my prosthodontic man provides me, and we screw it in 5 or 10 minutes. It depends on the rate of the compressive in the gingiva. And you check the occlusion is just in the front area of the patient. No contact in the premolar or molar zone. And this is the result of this type of surgery. And you can see the happiness of the patient with a good way, good issue. So my conclusion, it's a scientific validated technique with a well-guided protocol. You've seen it's easy to repair and an easy maintenance with a water jet water peak, and cut cost, of course, and 20 years of predictability. So I thank you for your attention. And I thank too Michael and Andrea for this great moment, and I hope that I be clear. Sometimes my my language in English was not so easy, but I think you apologize me because the important way is to understand the technique. So thank you very much, and Michael, I give you the. Hello?
Damien,
Yes.
here I am. You can't see me yet, huh? But
Yes, perhaps not yet, but it's coming.
yeah, but nevertheless, hey, thank you very much for this very comprehensive presentation on the all-on-4 technique in the edentulous patients, upper and lower jaw, using different implant systems, because you have referring dentists sending their patients to you to place implants, so they ask for different implant systems. And well, in your cases, actually, so I just can start my video now.
Okay, I see. No.
Okay. Just 1 second, I should come. I should be able, but you could just stop your presentation.
Okay, yes.
Damien, please. Then we should be able. Here we go. Here we are, Damien.
Okay.
Hey, thank you very much. Really,
Fine.
I mean, you have a lot of very impressive cases, a long history on those cases, and you have your special technique. And but the first question actually is probably the question which people always ask when you talk about all-on-4. And this is, what happens if you lose one of those 4 implants and you only have 3 left? So,
okay.
Damien.
There's two cases, a situation if you're losing a frontal implant or a distal implant. If you have a lack of stability of a front implant, lateral incisor is very not a problem, because you can, if the other 3 of implants are correct, have good integration, you check it just 3 months after, and the patient don't feel it. So you unscrew the bridge, you control the osseointegration, and it's only you inform your patient that one implant is not correct inserted, is not correct healing. So you remove this implant, and you can replace the prosthesis only on 3 implants for some months, and you can let this area healing, or you can decide to make immediately a new implant placement. And you make like the first days, as you take a rendezvous with your prosthodontic, and you check the calendar, and you do a new surgery. You cut the prosthesis, you place your implant, you connect your prosthesis with the new implant and the new cap, and you give all to your prosthodontic. And at the end of the day, they send you back a new prosthesis or repair prosthesis. And you say to your patient that stay carefully with the biting for 3 months more. And the second case is when you're losing, and I show it with a mandibular case, when you like your implant, your posterior implant, and the failure of this implant sometimes is a little bit more difficult to explain to your patient, because sometimes you have to cut the prosthesis. 3 implants are correct, but the last one is not good, so you extract it. If you have the place to place another implant, you choose to make it on the same surgery. You unscrew the failure implant, and you place a new implant. You decide to choose
Mm-hmm.
On one hand, you choose to connect it because you obtain a good insertion of your talk of your implant, and you connect it to the prosthesis. You talk to your patient. You ask to observe the same diet stage for 2 or 3 months to avoid to bite on this side of the mouth. And if the bone is not a good quality and you need to place the implant with 2 stages of osseointegration of healing, in this case, you cut the prosthesis and your patient conserve the prosthesis fixed in his mouth, but is reduced length of biting on this side.
Well, the most important message, so what I can conclude really from what you told us now, to answer these questions, really, it's not hopeless, huh? Because maybe we are afraid quite often, we lose one implant, so actually the case is actually busted, huh? So we have to probably start from scratch, but actually, due to your experience, you can always actually save the case, reinsert an implant at the later, immediately in later stage, and then come up to once the implant has also integrated, then to provide then the final prosthesis a little bit later. No? So there's always a solution.
Yes,
Apparently.
each time.
Yeah. And then there are more questions coming in. Why don't you use guide? So I suppose this means why don't you use guided surgery? You use the orientation guide. We actually
Yes.
the orientation aid, but why don't you use guided surgery is a question here.
Okay, I tried 10 years ago to use guided surgery, but at this time, it was difficult to provide a guide of cut to make the osteotomy, the horizontal osteotomy. And when you are cleaning up the bone, you don't know what is the quality of the bone you will find during the surgery. It's not rotten on the X-ray. So when you are drilling the bone and shaping the bone, like I show you on the last video, you don't know where you can stop because the bone is guiding you. So if you decide to use a guide, you can make some mistakes. You sometimes you can mandatory yourself to conserve some bad quality of bone because your guide decide to you. It's not you. It's
so you are less
guide.
flexible. You are less flexible in case you have to adjust your surgical protocol, implant position or whatever. So of course with a guide, you are fixed, no? Whereas when you are doing it like you, brain guided, then you have more flexibility and it can adapt to the individual situation.
Of course, but I know it's the more difficult approach when you are beginner, because you can be afraid about this. So I can advise you to make your guide and to try to use it, but it's not a loss of time if you make a guided surgery, even if you don't use it, because you can see the exit of the neck of your implant. It can show you the angulated of the implant. It can show you the choice of your angulated abutment. So I think it's not a waste of time.
Yeah, this is very interesting because what you were just mentioning, that maybe you have the experience, but maybe for beginners, could be guided surgery could be more helpful, because we have another question actually, which is exactly asking what should a not so experienced surgeon pay attention to when trying this concept for the first time? That's a good question, huh? That's a good question, yeah.
Yes. When you're trying this surgery for the first time, of course, you have to choose, and it's not automatically a good advice. You have to choose a full bone case, because it's easier to place your implants, because you have to check your angulation of your drilling, and it's not easy to change your mind. You have learned to place straight implants. So when you have to tilt your implants and tilt your drill, it's not easy, and you have two curves. You have to follow the curve of the mouth, because you are starting your drill in the bottom of the mouth, and you're going with the end, the extremity of your drill in the front. So because it's an arch, you have to turn a little your contra angle, and it's difficult for starting with this. So if you take a full bone case, it's better to avoid some windows in the apex of your implant. So you take a fully bone, and this is a good advice, because it depends not on the quality of the bone. If you have a lot of bone, if you have lack of bone, if it's very high skill level of bone, each time the all-on-4 is working. So you don't need to have a little bit volume of bone. If you have a full bone case, you can do your full arch. It's just more easy for you. But be careful, because sometimes you have to very make a huge osteotomy, horizontal osteotomy, to hide the connective zone between the resin and the natural gingiva. Yeah. So be careful of the lip line and the smile line, because this is the first risk of a big mistake and so a failure, aesthetic failure.
Yes, thank you very much, Damien. If I can conclude, actually, so it's really, you have to choose the appropriate case, no? Because to make your life easy, you really have to make sure that you have enough bone volume vertically, and horizontally, no? And
of course.
And really that the patient maybe with a low smile line is more forgiving, no? Because then you don't have to reduce maybe the alveolar crest. You can place your implants without any reduction and still can hide the junction between the soft tissue and of course then the restoration, which should not be visible, of course, when the patient is smiling, no? So that's a very, very crucial point, and I hope that this will
for sure it's better to choose a patient with 5 or 6 tooth in the mouth, not a total dental patient, because it's very difficult, and not a full teeth patient, because the surgery is more difficult to appreciate and to manage. So the best case is like you described, with a low smile line.
Well, I think we could continue for another 30 minutes, because I mean there are some more questions, of course, but I think unfortunately time is up, Damien, because it is now 7:30, and I really thank you very much for your very comprehensive and very interesting presentation on your clinical experience with the all-on-4 technique, as well on the use of the CONELOG progressive line as well as the screw line, because you use both systems depending on the indication. No, the good thing is, of course, that both prosthetic wise they are perfectly compatible, same components, which facilitates, of course, the life. And I would like to say thank you as well to the participants for their time, for being present for this webinar, coming from all over the world. And with this, I would conclude this webinar. I would just mention that we will have another webinar coming up with Professor Juan Blanco in November 16th. Same topic, CONELOG progressive line implants. So please make a note that there will be another webinar. And Damien, we say thank you to our participants. We wish them a nice evening, a good day, wherever they are. And you as a French guy, you will probably have a nice dinner tonight afterwards.
Yeah, thank you. Thanks a lot, Michael. And thanks for all of the people of different countries take the time to listen to my presentation. Thank you. Thanks a lot for you too.
Yeah, and the video will be available on the BioHorizons COMFOUR homepage after some time on demand, so you can see again the video if something, I mean, you want to see something again, you know, some tables, some information regarding this technique. So have a wonderful evening. We say thank you, Damien, and comment on dit en français, à bientôt. Thank you very much.
Merci.
Merci beaucoup. Merci.
Merci beaucoup. See
Thank you, Andrea,
Bye.
as well, for your support. Bye bye.
Thank you.